jump into things, but emergency medicine, for some people, very easy jump. For others, not so much. It's a completely different type of medicine. Completely different type of medicine. Again, there's your reference. So, because I'm a professor, they actually sent that book to me for free. So, you get to that level, you can write any book company as long as you're teaching their curriculum and your source, they'll send that to you. So, but seriously, like anywhere from $300 to $400 book. Awesome. So, here's your objectives. So, very important in the emergency department that we set ourselves up for failure, and we set ourselves up in the event that a patient decides to crash on us. And he'll crash. You want to be ready for that. So that's what we talk about, the safety net. Get into a bunch of these other types of issues which you should have. It's a general pattern for how that we assess patients. But just remember, we kind of have this interesting continuum in the emergency department. We go back and reassess, we check our interventions. And then we go back and we talk to the patient. Are they feeling better? Have vitals changed? Did the labs change? Are they getting worse? So making sure they're getting comfortable and hopefully getting them disposed where we can send them home and not send anybody home without abnormal vitals. Or do they need to come into the hospital? Well, good news, because it's Tuesday. So let me preface this with exactly a month ago I took my Panry. And thank God there was a lot of emergency medicine on there, or it would have crushed me. But it did. And there's things on here that I'm going to keep testing you on, because yes, I did have to calculate an ACS on the Panry. I was like, sweet. I got one question. Good. Anyway, so you may see some strategy questions that are going to be on the PANS, but usually not what you're going to see here in your phase 1 or phase 2. Here's what we're looking for with emergency medicine. We need to rule out worst case scenario first. So every patient that I go in and see, I think worst case scenario first, and then start whittling it down. You don't want to miss something that's at the top of the truck that's going to kill your patients. So, top 3 things, medical litigation-wise, with pediatric patients. What do you think number 1 is that gets missed in the emergency department? Meningitis encephalitis. Number 2, upper extremity fractures, because little kids are bendy, and some of them are really very resilient. Number 3, testicular torsion. Top 3 things that go to court and people pay out big money. So we got to rule out those worst case scenarios. So sometimes we're like, I don't really know what it is. I tell patients, what's your expectation today? I may not figure exactly why you have chest pain, but I'm going to take heart attack off the plate. I'm going to take pulmonary embolism off the plate. I'm going to take aortic dissection off the plate, pneumonia, all these things. But I may go, I don't know, you just have chest pain. There's nothing that's going to kill you. But if it gets worse, come back and see me. So most of that is ruling these out. I encourage you, when you get to phase 2, to cast a very wide net. So you start figuring out where your lines in the sand are. So I say that, you're going to think that, well, it could be this. And I'm not saying go out and hunt zebras all day. And don't order dimers on every single patient. But D-dimer, everybody knows what that is, right? It's a check that there's fiber degradation. Typically means it's evidence of a clot, but it can be elevated for other reasons. And if you get an elevated D-dimer, you're obligated to CT somebody's chest, so be cautious with that. But we have certain rules that help out. But I'm encouraging you, when you get to phase 2, cast a wider net. So you start figuring out where your lines in the sand are. I get a 20-year-old with chest pain, I'm going to get a chest x-ray and an EKG, and that I'm going to call it a day. Unless they're like, well, I've had pleuritic chest pain, I'm on estrogen, I'm tachycardic, and I'm like, uh-oh. Well, now we can't perk about and talk about those types of things. So, totally different way of thinking. We got to get out of the primary care realm. Primary care and start thinking emergency medicine. You have old people, you got young people, you got people that are immunocompromised or have multiple comorbidities. So you got to get away from the primary care. So I want to make sure what is the threat to the patient's safety, not necessarily how common things are, like we think with primary care. So assume the worst. Assume the worst. Here's an example. Patient comes in, chief complaint. I have a sinus headache. Well, you think headache, cool, I'm just going to take care of that. But really, you may be thinking, is this a subarachnoid hemorrhage? Is this encephalitis? Orbital cellulitis? Is this a glaucoma? And they're older, and that's how they're communicating their headache as eye pain. So, brain tumors, unfortunately. We have all these different venous sinus thrombosis and other life-threatening things. So, if we're going to make some diagnosis, it's common. It needs to be probably a diagnosis of exclusion. We'll rule out all the other bad stuff. So, what do we see in this? Yes, acute resuscitations. Based upon your phase 2 site, you may see a little bit more. So Bambacy is the only level 1 trauma center in all of the DoD. So they have a particular pod there called the Charlie Pod. Charlie Pod, probably on the hour, every hour, you're either going to hear a code. We talk about codes. There's 2 main ones. I've seen a third one in some places, but we have a code stroke, which time is brain. We have a code STEMI, time is heart. Then I've also heard code sepsis in some place. And a lot of places will have little cards to tell you how do I handle status epilepticus and things like that. We'll get into all those types of things. You will get an opportunity this semester, a lot more hands-on things, IV lab, RTA lab, and then we're going to do ATM lab with goats. So it's going to be pretty exciting. No, they're not cute and cuddly. They're definitely not built for yoga. They're huge, usually about 80 pounds, but you will work on things like hemorrhage control and airway and different procedures. You have a chance to do that with live tissue. There's nothing quite like live tissue. Those of you who've done live tissue understand that. So, PETA knows it. Not my fault. So, just remember that there's variations in these types of things. So we're not trying to make case reports, but occasionally things will present atypically. So be aware of that. And then we need to make a difference right now. We need to act on something. You have your patient split between your history and present illness. You got time to ask questions, time to figure them out. Your other patient, they're coming in, code in progress. You don't have time to figure things out. And watch how people lose their stuff. I teach ALS. I have plenty of folks that come in and they're fumbling through the chart and they're freaking out. And I'm like, calm down, it's okay. Like, what do you mean? I'm like, it's a man. I'm a real person. What are you freaking out for? So imagine how people do when there's a real person there. And they track all that stuff in hospital. It's pretty sad. Pretty sad. Anyway, so make sure that we set that safety net. So if we can, we want IV access as soon as possible. Pretty hard to get IV access in a person who's in status epilepticus, right? And you're probably gonna have to go IM on that. But just be aware of that. If we can set these things in place early, we definitely want to do that. We act on those vitals, we should be doing something immediately to adjust those vitals. If they're febrile, we should be giving them some type of antipyretic. If they're tachycardic, maybe we should think about fluids. If they're hypoxic, they should probably be on oxygen. So we want to get those things in place. Your emergency department should have an airway cart, and it has all different types of devices. You can roll that bad boy in there. You can roll ultrasound in. They can come shoot bedside x-ray, and then you have to consult people sometimes very quickly. So this is all meant to help guide you through your thought process, to give you instant answers or as quickly as you possibly can in order to make decisions on what do I need to treat and where am I going to give a disposition to, and then what do I need to do to follow up and maybe return precautions. Strict return precautions are very, very important. So a little bit different way we're going to teach this. Like I said, it's just kind of a jump unless you've had a lot of experience in an emergency department or around that. So we'll do enough check on learning to give you an idea of what kind of scenarios, but most of the stuff that I had on my pantry was pretty solid as far as being sick. So sometimes we need to make a decision. It may not be the right answer long term, but it's the right answer right now. Meaning, if you think a person comes in that they've been overdosing on something, what's your most important lab right off the bat?
What drug it is? Drug panel?
You need to get a glucose for an overdose. I need to see what's going on. Why are they altered to make sure that it's not glucose? Why? Because how fast do you think you're going to get any drug screen back? I haven't seen them come back quicker than 3 days. You're not making decisions on that. You have to use everything else. That's going to be. We'll do a brief intro to toxicology, I believe, in block 3, where I explain some of these concepts to you as far as what do we look for, what's called toxidromes, to pick have an idea of what's going on. Not everybody's going to come in with a pill bottle right next to them. So we have to be able to use our vitals and our good physical examiners to figure it out. And then you get poison control on the phone. So we need to be able to recognize that right away. If they are hypoglycemic, that's very easy to take care of. It's like a stroke. Like I said, they come in altered. You get a glucose, because the last thing you want to do is call a code stroke, and like glucose is 20. You're like, oh shit. Now you look like you don't know what you're doing. So, seen it happen. So, hierarchy of that bedside, obviously ideal. Keep in mind you're going to have a different clinical space. Your patient's going to be in their own room. Maybe there's family in there, and that room should have most of the equipment that you're going to need. Most of the equipment. Now keep in mind, on shift where you're probably starting out on your shifts, maybe 1 to 2 patients. You'll probably be pretty well endowed with that. Now, I usually hit about 10, but I've been doing it for a little bit. And that's just a lot of bouncing around, and I don't want to lose that edge, because then I go to my locker and there's my big slip. You're off the team. Anyway, just have an idea of this. There's a couple things I want you to focus on. There's going to be a lot of different rooms. BAM sees 4 different pods. Your emergency department is going to be something different. But just to give you an idea, you want to get oriented to your emergency department before you start your shift. You want to have an idea. And what are some interesting things here? So most of the time they're going to have RADs right there in the emergency department. There's a CT scanner over at radiology, but there's also a CT scanner maybe in your emergency department. You have your administrative areas. You're probably going to be sitting at the desk, not in an office. Sitting at the desk where you're central to all your rooms, right in the middle there. What I want you to pay attention to, ambulance bay, you need to know where that is, and then isolation rooms, very important. If somebody that comes in that has had some type of exposure, you need to get them in isolation, because the last thing you want to do is have more patients than you can handle. Okay? So that's just to give you an idea of how that works. This is just an example, but orient yourself to your emergency department before you start your shift. Pretty easy. Either your fellow classmates can show you, or if you end up at Fort Hood, Vamsey, El Paso, or Madigan, those are the 4 places that have emergency medicine PA programs. So if you're there, they will gladly bring you in. So again, we're talking about emergency medicine. I don't know a bunch of things in depth, but I know a lot of things in breadth. That's all that means. We know a little bit about a lot, not a lot about a little. So very important. You have to be able to be very good with your hands. You need to get your physical exam down pat. It's very important you do a lot of neuro exams, and then hopefully have a lot of chances to do procedures, anything from sutures, staples. Good luck with an intubation. It's probably more of a thing where they're going to want you to do that in a environment that's been set up, like you're doing your surgical rotation, and maybe the CRNA or the anesthesiologist will let you get a couple tries. Just be reminded every time you intubate somebody, if you don't get it, you're causing trauma and it's going to cause swelling. So you will feel scary. So again, we're not particular specialists. We do a little bit of everything. We use a lot of different modalities. We're going to get you guys savvy, at least a little bit, on ultrasound. Who has used ultrasound before? Okay, good. Got some folks in here. The military's looking at, Army's looking at fielding that, but I'm sure they're going to go lowest bidder, so sorry. We've got nice machines here. But we want to get you to a point where you're good on the EFAST. Good on the EFAST. Probably some DVT, some ocular, and then maybe look at some soft tissue stuff, vascular access. Especially if it's going to be fielded in the near future. I don't want it to sit in the corner of an aid station just gathering dust. So we ask consultants to come in, specialists. We need to pick up the phone early if somebody's sick. Case in point, for 3 years straight, I just happened to draw the short straw and got Christmas Day. Not fun, but guess what comes in on Christmas Day? Sick crap. So I'm signing out with a buddy of mine. And I was like, what's going on with that guy over there? And he's like, oh yeah, he's probably got Ledwig's angina. You guys familiar with that space-occupying lesion, sublingual area? Well, I said, let's go check him out real quick. He's tripoding. That's not good. Hard to be given racemic epi. So I looked at the nurse, I said, call ENT and anesthesia right now. Well, they're going to want to talk to you. Cool, they can come down here and talk to me. The second they got down there, didn't say a word, And every ENT resident went in that room to scope that guy. He was in the OR in 5 minutes. But right before they left, they said, "What's his COVID status?" Does it matter now? Like, everybody's been in his room. So anyway, Penrose drain, induced coma, intubated for about a week before that cleared. The dude was only like 34. Letter extension is secondary to post-op tooth extraction. Only like 37. So make sure you call those people. We need to look in that person. Do we need to admit them? Do we need to transfer them because we don't have capabilities in our hospital? As potential, believe it or not, FAMC has gone on STEMI divert. Blows my mind, but we'll be able to handle that stuff and labor deck and calling the right people. We do not like people that end up in the morgue, but that's an inevitable thing. I want to talk to you about this continuum. This means that this can go any way, shape, or form. So you may be treating the patient, and now we're going to be going back and they want some more lab tests because you just called internal medicine. They're like, "Oh, you didn't get procalcitonin? Okay, whatever. Just tell me what you want." I do that when I get off the phone with my when I consult and I say, "Hey, is there anything else that you want?" So I can go and order it now. So they're about to go upstairs and get the CT scan on the way up. Anyway, so I talked to this. Just realize this is continuum. You can go back and forth, move around, very high-paced environments. In most places, some MTFs maybe not so much, but when it does come in, it can get very hectic. By that way, I also would say it's a good time for you to try and work on some weekends or Friday nights when people get extra stupid. It makes for a better time in the emergency department. It really does. Making sure that we're triaging these folks in a certain way that we triage them. Just be aware that this can be an ongoing process, meaning they can go up, they can go down, get better, get worse. But just be aware of that we're looking for that. So disaster triage is probably what most folks are used to, MassCal. So I don't think people will say that a hospital's had a MassCal. Every time that I've seen a lot of patients that were coming in at a hospital, there are more doctors than there were patients. That's not a MassCal. MassCal is when you're downrange and like 20 dudes come in and you and 3 medics, that's MassCal. Anyway, so just be aware of that. Be careful with these triage things. So sometimes people that are triaging out the front, now they've done a lot better about putting a provider out there. Not to say that nurses aren't doing a great job, but usually somebody that's working the ER can just assess people, maybe get things going a little quicker, ordering some labs, doing some interventions, and helping that person out. But we go with what's our ESI category. So that is how we gauge that. Majority of what you're going to see is probably going to be 3 or 4. If it's a 1, that's usually CPR in progress. So again, not testing on all this stuff, but we want to make sure if it's life, limb, or eyesight, those are our primary concerns. We want to intervene on those as quickly as possible. But I always had a couple docs that said, "Hey, in the process of figuring out what's going on with your patient, make them more comfortable." So that doesn't mean give them something to eat, but if they need a blanket, hook them up with that. Emesis bag before they puke all over the floor, and then probably getting some antiemetics on board, fluids potentially, temperature control, early antibiotics for our people that were concerned of with sepsis, and then again, load the boat. Load the boat was what I did that day when I said get EMT anesthesia down here right now. Because if I was going to give an airway in that gentleman, it was going to be a crike. I wasn't going to dare freaking try to intubate that gentleman who's got stridor and tripoding on him. So right off the bat, go back to ClinCore, we need to look at that chief complaint. Chief complaint, and if they're altered, maybe they're not communicating their chief complaint as well. They're poor historians. That can hurt you. Look at the vital signs. If I see vital signs, I know what I need to do right off the bat. If they're abnormal, I should be doing something intervention-wise to change that. And then obviously your initial appearance. Which is why it's very good. Make sure for your ClinCore you are saying, what is my initial appearance of the patient? When I get boards, or I take boards, and I look at them, I say, all right, I walk in the room, what do I see, hear, and smell? So that I have a good idea of what I'm going to say to my patient. Because it's a little bit tough when we're doing these simulations. We can each other. A little bit more difficult, but paint that picture. Paint that picture. And then when I have PA students or my residents, and they can walk out of the room, usually PA students, I want to hear, are they sick or not sick? Are they stable or unstable? Because if I hear sick and unstable, I'm not waiting for the presentation. We're going to walk in the room. We need to do something about it. And then I can hear about that. But we need to make sure we get our safety net in place and that type of thing. And then right after that, I feel like we just have that idea of it's going to discharge this patient, or we may admit him. Now all this seems like a blur, right? And it can be, especially when you have a bunch of sick patients coming in, you're bouncing from room to room, you're trying to keep up with things. So it can get very blurry. But what helps me out, what really makes me calm down, is when I get my safety net in place. So I'm going to get this guy on a monitor, or girl, and hopefully that's giving me all those different information pieces. ID, if I'm really worried and they're hypotensive, I'm probably going to say, hey, let's go 2 large bore. And I'm talking like 14, not 18, O2, and then I say, let's get the airway cart and the crash cart. By the way, at the start of every shift, there should be somebody that's going through and assessing that, making sure that there's every size tube in there, that there's medications, that the crash cart hasn't been popped open. So, and this just sets me in place, allows me to pucker a little less, so I'm ready to go when I have safety net in place. Like, I don't want to try and get an IV on a crashing patient, an IV on a patient is easy. We do focus that history. So if they're coming in with an ankle injury, I'm not going to look at their ears. So make sure appropriate. We don't have loads and loads of time, and there are a lot of older folks or lonely folks that like to come in and carry on a 5-minute conversation. I'm not saying that I don't have empathy or sympathy, but I'm going to ask the questions. I'm going to make it very direct. So I'm just like pertinent positives and negatives. I'm just going to rattle off things. If it's a yes to any of this, tell me. And I'll say headache, eye pain, nose pain, nasal discharge, sore throat, chest pain, shortness of breath, abdominal pain, nausea, vomiting, diarrhea, and just da-da-da. Now occasionally I get the patient that comes in and goes, yes, 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 yes. Those are cluster B, okay? Schizophrenic personality disorders. It's rough. They're like 38 and they're on 20 different medications, guaranteed fibromyalgias in that. And those are the rough ones. If they have a psychiatrist, they figure he sees them on Tuesday, all of them on Tuesday. You want to see them on Monday, but you don't want them for the rest of the week. So, anyway, chief complaint, we want to look at that, and we want to see if the patient, can they respond to us? Are they altered or not? They should be able to tell us, who they are, alert and oriented, and then we want to look at that morbidity or mortality. Morbidity being, is it affecting their quality of life? Mortality, has there been any loss of life? And then keep in mind, if that person's altered, let's say you get a lot of folks that are brought in from memory care facilities, from nursing homes, that there's nobody there to give any report. You're just kind of like stuck with it. They're trying to figure that stuff out. This way you get really good at looking at medications and just kind of figuring out people's past medical history if they're not completely with it. But just be aware, if EMS comes in, you better be right in that room. If they're going to give a report, they're going to give a report one time, and as soon as that patient's dropped off, they're out. They're out. You didn't get there to get that report. That's on you, but ask the witnesses, family, medical providers, anywhere you can get that stuff. You need to be acting right away at this. Obviously, these are the types of things that this becomes a contact sport where we need to get involved right away. Obviously, CPR is in progress. CPR. Sepsis, time, antibiotic, we need to get moving on that in altered mental status where we can do seizures. So that is your action patient, not your history of present illness patient. So, and then figuring out medications and dosages. Most of the time we can get that from the computer. That's great. Some older folks actually come and they're like, here's my paper, and they have everything. That's pretty amazing, but it's not always the case. When appropriate, we ask about social. Current living conditions, you have a lot of elderly folks that come in. You're also going to have a lot of kiddos that come in that maybe are being neglected, non-accidental trauma, but you can also have older folks that they live by themselves and they're not able to care for themselves. It's not right to send them home. So some people will call that a social admit, but we have to call him and say, he lives 2 stories up and he can't walk. How's that going to work? We set people with failure. So we ask about tobacco or nicotine, alcohol. I usually preface that with like, hey, I need you to be honest with me because most people aren't. Most people aren't. And their allergies, luckily within MHS Genesis, there's a little nose that lets you know that that person has an allergy. Last thing you want to do is give somebody a medication that they have anaphylaxis to. And believe it or not, I think one of the craziest ones that I've seen a whole bunch, allergies to insects, anaphylaxis. So give that person a shot of Toradol. I've had people get shots of Toradol in the urgent care and come in to see me on the main side of the ED in full on anaphylaxis. So, and what's the first thing I do after I take care of them and get them stabilized? I document their records. I'm be real careful about that. We talk about primary surveys. You get a little bit more focus on this with trauma, but just to kind of let you in. So we get our ABCs. That's the big thing. Not going to go to DE, move on from that. You'll get more in your trauma. But we really, I mean, airway, how do I check that? I say, hey, bud, what's your name? Or, hey, Miss Lady, what's your name? They can respond with their name. I'm like, okay, airway's intact. That's great. I'm going to listen, auscultate the lungs, make sure I got equalize all, listen to the heart, check pulses, and moving a lot. But as you're doing this, you're yelling it out because you're probably going to have somebody in the back of the room who's going to be recording all that stuff. So again, vital signs match what you're seeing. They should. You should. Just be aware if something seems like it's off. For the most part, most emergency departments calibrate all their stuff and go and check it every year. It has to be certified. But those people have these little crappy wrist BPs. They're horrible. They're worthless. You see one, throw it away. Terrible. But just be aware. You may need to get additional vitals. The secondary survey, thorough but focused. Here we tell you what is the most commonly missed secondary survey category of medicine in a trauma patient. Orthopedic injuries. Orthopedic injuries. Most of those people are too altered to tell you that their leg hurts. So if it's not blatantly, obviously deformed, it can be a little bit difficult. But again, tailor your physical exam. So abdominal pain doesn't necessarily need your new cranial nerves. So I'm not going to back of somebody's eyes if they've broken bone, but definitely everyone should you should document heart, lungs, and potentially abdominal exam in everybody. What we really want to differentiate on that abdominal exam is that pain above or below the umbilicus. Okay? Above or below, because that just runs into a whole different realm of where things are. Is it intra-abdominal? Is it extra-abdominal? So, I'll tell you guys all about that. I think I told my clinical. In phase 2, I had a little kiddo come in with a fever. Worked him up, I looked him all over. I thought I did. And I went to my attending and said, I think it's fever abundant origin. He goes, well, we got to put a needle in his back. I said, yeah, you talked to the family, consulted him, took it in there. He goes, all right, you ready to do this? Yep. Why don't you do me a favor real quick? Look in his ears. Damn it. Looked in his ears, full on raging ear infection. And now he's about to put a needle in his kid's back. So I think for a year after that, everybody got their ears looked in, regardless. A couple different data gathering things that we rely on in the emergency department. Not necessarily, these have mostly been validated in the emergency department. So obviously we're going to use our labs and radiologic studies. We have all these different pre-lab probabilities. What is a Wells good for?
Mental?
So deep vein thrombosis,
Okay.
or thrombosis. So it just gives you an idea of that. PCARN. That's a decision rule, and you can look up any number of these on MD Calc. Just plug these in. Questions you ask. PCARN was over 10,000 kiddos. That's a ridiculous end. Like that's an impressive study. Like you can use that. That's clinically statistically significant. So PCARN is head injury rule for a kid, whether or not you should CT him or not. Whether or not you should CT him. Your ASEP. So American College of Emergency Physicians. You're going to have your clinical practice guidelines, which are really going to tell you how much anesthesia you're okay using, how much pain control you're okay using, And then you're going to have your standards of care, your evidence-based medicine as well, which really, that EM basic will really help you out with. And then your institution is going to have some guidelines. And what they do with the emergency department, they will provide you a lot of what I consider algorithm-based medicine. Not always my cup of tea, but if you tell me the way to go, and I can get to it, and I give you a phone call, and I say I followed it to a T, and I still don't have an answer, and that's shame on them, but at least gives you a good framework for how to do that. So there should be a repository somewhere, somebody in your emergency department, your phase 2 site, is going to have access to everything that you need. And what are the two big things that you need? You better have a code stroke packet, you better have a code STEMI packet. And that literally goes to the nurse, you almost click a button and it orders everything, and it's like going all the way on your own. It's great. So differential diagnosis, obviously, we're going to put all this stuff to the top. So we're going to base that initially off our vitals, our history of present illness, and physical exam. So when you adjust that as you get more information, whether or not you're going to rule stuff out or add stuff on, I'd like you to come back with me at least 3 to 5 diagnoses. Now, it could be way more, but you're only going to diagnose what's on your differential for the most part, unless it comes back with a CT scan that says it is blah, blah, blah. Just keep in mind, we like to get things moving fast. Emergency departments, for the most part, are based upon the left without being seen numbers. How many patients came in, got tired at hour 6, and left? So, and most people don't realize what's coming in by EMS. That's transparent to them. And I tell people that. Like, hey, I'm sorry you've been waiting so long, I'm apologetic, but it's been a really busy night. A lot of people come. And guess what? Most of the retirees know. If I call EMS, if I come in by the ambulance door, I have to sit in the ER for 6 hours. Yeah, they know what they're doing. So anyway, team effort. You got to play well with everybody. You're going to have techs, you're going to have medics, you're going to have nurses. I don't poop where I eat, so you're not going to get along with everybody, but trying to be a good sport about that stuff. Realize that you need to do bedside labs. Every emergency department should have bedside labs and get that glucose. iStat capability is a great capability. That's like instant results. I can get a lactate, I can get hemoglobin hematocrit, I can see where that potassium's at. There we go, lactate. I can get a pregnancy test. Most of the time, triage has to be taken care of. If it's a woman of childbearing age, she's coming in with any abdominal complaint or potentially being pregnant, she will likely have a UA and at least a urine HCG that's taken at triage, and hopefully by the time she comes back to the room, that's at least done. Keep in mind, stat, 1 hour time period. Yeah, that would be great if it always came back. Doesn't always happen, but that's what they shoot for. And if these people are sick or unstable, they do not leave the emergency department. They leave the emergency department because they have to go down and get a CT scan. That's where they can die. We do not want to go take those assets. We're very careful about that type of thing. That EM Basic is really what started helping me wonder why. Why am I ordering this lab? Why am I doing that? And if you're not really sure, you're like, man, I want to work this patient up. Most of the time, the radiology department have no problem. Just find out where they are. Just dark room listening to techno music. That's what they do. But at least know where they are, because I'll stick my head in and attending in a resident, and I'll say, hey, I got this guy, here's what I'm thinking, and they'll probably talk to me and give me an idea of what I need to do. So just keep in mind that you are responsible for your patient. So if that consultant comes down and says, ah, they're fine, you just discharge them. If you're not okay with that, that's not going to be your battle in phase 2. That's you and your attending going, I don't know about this. If I have it out, I'm not usually let my resident handle it. The resident disagrees, and I just go to the resident and say, get your attending, and then I handle this. So most of the time, it works out pretty well, but just realize that military medicine, I told you, is not revenue driven. So there's not extra money in the pot if you see extra patients. In the civilian world, that's a different ballgame. Doctors will be like fighting over patients with that cat run. So just be aware that you're responsible for that patient. If you're not comfortable discharging them, let your attending handle that kind of thing. So medical decision making. This is a big thing as you start getting into your soap notes and whatnot. This is a big portion. That is huge in emergency medicine, but I'm going to tell you right now, you should probably get a little bit more comfortable with this, with what you put in your notes when you after your pants, with what you deal with patients, putting in what you're thinking, what you think it's not. Also potentially what I used to do, because you're seeing a patient every 20 minutes, I would also put, if they came in the next time, what I was thinking that they would recommend. Because soldiers will window shop. Okay? They don't like you because you won't give them a 3-month profile, or you won't give them narcotics or whatever. They'll go to your compadres. So just be aware of that. But I'm just going to give you an example, but we're putting in a mix of our soap note as well as our labs. And our labs and our radiologic studies probably hold a little bit more weight. But here's just an example, and I'll let you redo this. So nobody ever is going to want to see me type. Why? Because I've been dictating for the last 10 years. So my typing is atrocious. But I can dictate and I don't stay a minute past my shift when it's over. I get my HBI, I dictate that. I put in .ROS, and it puts in my review system, click my pertinent positives, .physical exam, or PE, put that out, and then I rattle off all of this on medical decision. I would say it would have been nice for this particular one if they had put in an EKG, probably with chest pain. Because the EKG shows no electrical evidence of ischemia, infarction, or arrhythmia. These are just smart terms to use. But this is what's going to stand up in court if there's a bad outcome. What's going to stand up in court. So, and I don't need you to sit there and like try to work through this. You can type in MDM wiki. Last time I checked, nobody gave a crap if you plagiarized your note. At least I've never got into trouble for it. So anyway, dot phrases, all that kind of stuff. And then maybe because you did some type of procedure, you're going to need to be able to look that up too. And you can rip all this stuff off the internet. If you want to, you can build your own Word document that's going to have all those procedures. Exactly how many sutures did you place, how much anesthesia did you give, all those types of things. Always document how many sutures or how many staples you placed. Because somebody's going to have to take those out at some point. Probably not you. You want to make sure they don't leave anything. Okay. This just gives you an idea of a note of what they did as far as chest tube placement. And then we look at our disposition here. So when you consider a lot of different things, I will look at an age. Like, man, this guy's 98. If he's good, he probably shouldn't have been in the ER because now he's got something. Some comorbidity, some type of thing he's gathering up from there. And then living conditions, we need to worry about that. So where are they going back to? Always consider, because you're going to be seeing a lot of military folks, you know, what kind of profile do I need to give them? Most of the time, it's usually no more than 2 to 3 days on the sick call form. You don't have to worry about the emergency department writing crazy stuff there. So, and then how likely are they to follow up? This was a big issue during COVID when nobody could get in to see anybody. And I was working in Bravo Pod Bamsey, the COVID pod. That's literally all I saw for like a year. It was horrible. But at the same time, I always had to think about, man, they're not going to be back in. So I work people up a little bit more. I say, here's your primary care. Well, you are. No, I'm not. But for right now, I'm the only guy you can get in and see. So you need to be aware of that. So obviously during COVID, we had very full hospital bed status. And it was very, very difficult. So, and then just figure out, well, where do we transfer this person if they're having a stroke? Because we have no stroke capabilities here. But you need to have an idea of that. And then if they are going to be going downhill, and if they have a poor response to your resuscitation. These are all factors in disposition. So, Make sure very, very explicit in your disposition with your discharge instructions. So I will say I would like you to follow and see your primary care. Most of these with MHS Genesis, you can actually click on the primary care, and a lot of times it will forward the note to them as well, most of the time. So specific reasons to return to the emergency department. I just say if your condition worsens in any way, shape, or form, but I list specific things: febrile, tachycardic, things like that. Give those instructions, make sure they have strict return precautions. Make sure they get a copy of that. And then there's another patient that you'll get, and that's called against medical advice. And it's AMA, and I've had a couple of those, like 3 specifically at DAMC. Just happens 2 of the 3 was the same person, whatever. Drug seeking, I don't play that game. So just be careful with that, but I mean, if they just are completely refusing everything, there's a chance you go in there. Just make sure your attending's on board with you, or that you have a physician that's willing to back you. Sometimes I will let my chief go and be like, can you talk some sense into them? Because I think that they really should stay in the hospital. And then you can print out these in multiple languages as well, just be aware of that. But not everybody needs to be admitted. We need to have good reasons to admit patients, good reasons to admit patients. So sometimes I have had to battle for some people, but I want to make sure that we do that in a professional response or special professional manner. Keep in mind, every hospital, all the lines are recorded. So watch yourself. I'm just saying, I've had to tell some people on the other end of the phone, I'm like, you know this is being recorded, right? Usually they're a little nicer, you're a little bit nicer. So again, until it's a good handoff until that patient goes upstairs, out the door of the ER, that's still your responsibility. So a lot of times, again, military medicine is not revenue driven, so be cautious with that. So obviously sick versus not sick. If it's sick, you should probably come out of the room and at least let somebody know. Remaining calm in these events where you're running the code goes a very, very long way. Nothing gets everybody in the room amped up and nervous as somebody that doesn't know what they're doing or looks like they're doing what they're doing. So keeping calm as much as possible. So be aware, elderly, children, and diabetics will hurt you. They want you to not continue to practice medicine. That's how it is, unfortunately. So again, don't send them to radiology if they're not stable. And don't just be giving fluids willy-nilly for not a good reason. I will give fluids to somebody if they cannot provide a urine sample. I'm like, okay, we're not messing around with you all day, trying to get you to provide a urine sample. So, time in that bed, that's why left without being seen is so important. They also watch how long do people wait in the ER. So, don't wait for that person to vomit before you give them anti-nausea medication. If you're giving them pain medication, you should probably be giving them antibiotics. So people that are narcotic naive will throw up like crazy. So, and what really stinks is you just need to be mindful. These older folks that come in don't plan on being in the ER for 10 hours. It happens. Do you think they bring their medicine home? Nope. So you might have to order those out and out. And then alter mental status, just because somebody's yelling at you doesn't always mean that they're just being an a-hole. So think about those other types of things. We'll get into that alter mental status in the next lecture. But we need to be thinking, obviously, if they're hypoglycemic, is there drugs on board, is there some type of underlying electrolyte disturbance, head trauma, all those others right there. So AEIOU TIPS is a great acronym for that. So alcohol, epilepsy, insulin, overdose, underdose, trauma, infection, psychosis, and stroke. There's your exams. So GCS is always in play. Okay, that's the only thing I'm going to have you take from this lesson. I need you to know this GCS. Again, I had to calculate it on my Panry. So you can be able to do that here. Here's an example of that. I want you to know the adult. I'm not super worried about the kiddo one. So here's that breakdown. 8 or less intubate. 3 is a comatose patient. 15 is normal. Questiones. Again, no check on learning for this lesson. This is more informative to give you an idea where I want you to start thinking with your heads. So some people will just a little bit more of a jump, but once you start thinking emergency medicine, You'll have me for blocks 1 and 3, Major Sandoval for blocks 2 and 4, and then we'll circle around the wagons to rock you guys some overtime. All right, please take a break. Be able to differentiate between these two. Again, your reference material. It's approximately 6 pages out of that technology book. Probably broken down to a lot less in the online version. And here's your objectives. So just keep in mind that as providers, if you do enough mental status exams, you're probably going to do well on them, perform on like the MACE with medics. And if you give a medic a MACE exam after any type of potential TBI, you're probably going to crush it because you've given it 100 times. Be aware of that, but there's 3 flavors. Again, we'll talk about the Glasgow Coma Scale and then kind of pathophys, clinical features. Goes on to a second page here. How we manage these, and then correct disposition. So obviously it's going to be ABC for this. I don't have an actual multiple choice there for you, but go ahead and read through that. Just kind of a warm-up case to get you an idea of what's going on, because I will explain this in more detail. So clearly coma is out, correct? Okay. And then we're down to 2 flavors. So, delirium or is it dementia? Right. So it's fluctuating and it's only been going on for a few days. Delirium, and why do we differentiate between delirium and dementia? Because delirium is probably going to have more of a medical process, acute, that's occurring, that's causing that acute change in mental status. Whereas delirium is a little bit more of a flavor of its vascular, idiopathic. But I'm going to get into this a little bit more. But here's your introduction. So disorders of consciousness, aka altered mental status, can be either or these or a combination. So arousal, content of consciousness. This is what the Titnali version is. That's just how aware somebody is to their self and their environment. How aware they are to their self and their environment. So, arousal breaks down into these 2 flavors. You know, how wakeful are they and what's their basic alerting status? What's their basic alerting status? Just gives you an idea of what's going on. Whereas content of consciousness, like I said, they're aware of things. That's going to be their self-awareness. Also, are they aware of how they're speaking, their language, how they're reasoning? Spatial relationship integration is just, can they understand how 2 or more things around them are related? Obviously their emotions, and then a whole bunch of this myriad, meaning a whole bunch of things of complex integration, really just human. Obviously we're going to get after this. We want to make sure that we're asking our OPP-QRSTs, same way we do with your clinical cases. And then if we want to go down this neuro exam, so mental status testing, so you do the mini mental status exam. We're going to check higher cerebral function. Clearly cranial nerves. Really cranial nerves. Everybody's familiar with this because you've done all this stuff in this physical exam. Luckily we transition, you don't keep you doing that type of stuff, but motor reflexes. Cerebellar testing is probably one of the most important things, honestly. So, if somebody can't walk a tightrope or can't walk from point A to point B, they probably have no business going home. There's something going on. That's a fall risk. Next thing you're going to do is they're going to come in with a subdural or a subarachnoid. So, and then gait testing as well. So make sure that you're doing that in conjunction with a good history. So maybe brief with your mental status exam. You can get me deep in this, but obviously you want to say that they are alert and oriented ×3. You can describe if they look disheveled, any mood or insight. And we start focusing on, can you repeat digits properly? Not just 1, 2, 3, 4, 5, that's easy. Have them count backwards. So long-term memory, ask them how old they are, when they were born, short-term memory, that's just, again, 3 objects don't make it super difficult. But just see if they can remember those within 5 minutes later. So, average adult can repeat 6, 7 digits forwards and 4 to 5 backwards. No problem. So, looking at the language, can they conversate? Can they follow basic commands? Keep in mind that 90% of people are right-handed. So, which means the left hemisphere dominant, which means the majority of what their defects are going to be is going to be language related. Language related, so very important to check on this. Your cranial nerves, your motor sensory reflexes. So things you can ask them, if they can conversate, can they draw a circle, can they touch the nose? Those are basic things they should be able to do if they're not altered. And then we get worried about that. This is why we do the cerebellar exam, the gait evaluation. So it's going to check involuntary activities within the central nervous system. So we're going to pay attention to coordination, posture. We're going to do rapid alternating movements. We can do heel to shin, finger to nose. So, and then gait exam as well. Make sure, so walk like a duck, walk, you know, if it's a 4-year-old, don't tell them to tandem walk. Tell them to walk a tightrope and crush it. So, but then we get into, here's our big flavors. So dementia, so that's going to be, they're going to have failure of their consciousness, but it's going to preserve alerting and arousal functions, whereas delirium is usually going to be arousal and content of consciousness, and then coma is failure of both of those. Keep in mind that sometimes these altered mental status can cross into the realm, muddy the waters with some underlying behavioral health types of things. We talked about that, hallucinations, delusions, things of that nature. Sometimes you make the waters a little muddy. You want to ask, hey, is this patient's baseline? If they're an older person, hopefully, you know, the spouse is there, or the caretaker. Okay, how long has it been going on? Usually gauge pretty well. So, checking their mental status. So, how well are they handling their emotions? How well their intellect, and you can test that formally and informally. Informally by just asking them questions about how they're doing, how are you feeling today, and formally by actually conducting some testing. So delirium was the answer for our question. Because why? It does this. Transient. It's transient of attention and cognition. So 4 different flavors of that they would kind of roll that under. So that's probably a neurologist coming in and saying, well, here's what I think. Is this confusion? Is this cognitive? Is this encephalopathy or just generalized altered mental status? Again, confusion may fluctuate with these folks. That's typically how we're going to see that. Fluctuating. Hours to days. That's what gives that away. And that's the type of things that you have to be able to pull out when you hit your pants. They're going to ask you questions like this. You have to be able to pick out hours to days versus this has been going on for weeks. It's more of a dementia or years or months or whatever. So the pants are very good about that. They're just going to stroke through you a little bit of tidbit to point you down the right direction. So again, because it's fluctuating, only been going on for hours to days, likely is a medical, not a psychiatric, medical emergency. Usually something like an illness, infection, MI, hyperosmolar state, whether that's hyperglycemic hyperosmolar state versus DKA. Sometimes that's how those people present, just altered mental, but if it's short. Just keep in mind that, look at that, 25% of people that come in the emergency department that are 70 years or older already have some impaired level of mental status or delirium, which is why I asked for the baseline. Is this their baseline? Is this how they act every day? Oh no, this just changed like 2 days ago. My sweet, probably delirium, and I need to figure out the medical costs. And here's a great slide for you just to give you an idea. So it usually involves widespread neuronal or neurotransmitter dysfunction. Here's your 5 generalized cause. Primary intracranial disease due to hepatic encephalopathy. So liver enzymes just get so overwhelming that it's usually from underlying liver disease. Liver's starting to fail. And then we get into systemic diseases. Unfortunately for our older folks, that usually starts as urinary tract infection and pyelo. Why? Because they're bedridden or they're to a point it's just poor hygiene. Okay, that's just the way that goes. And that usually will progress to sepsis. A lot of older folks, memory care, Alzheimer's, got their baseline to switch up real quick, and like, oh man, maybe it's probably underlying urinary tract infection. Just wrecks these older folks. But then we also got to think about our toxicology realm, whether they're taking any kind of medication, drug, whether illegal or not, and then poisonous plant exposure, and then drug withdrawal. We always got to worry about that, especially with alcohol, delirium tremens, or opiate withdrawal. People are in bad shape. And then any history of recent major trauma or surgery. So there's your delirium, develops over days, hours to days. We're going to see all these things are altered, including memory. So these people appear to be awake, but they're not firing on all cylinders. So now this is weird because activity can be hyperactive or it can be hypoactive based on typically what time of day it is for them. Typically what time of day. And how does that work out right here? Again, symptoms fluctuate, they're intermittent. So again, if they have different caregivers, they may be seeing them at the same time and they don't notice what's going on. But typically during the day, they're going to be more sleepy. Typically during the day, increased somnolence. And at night, they're going to get agitated, and that's called sundowning. No bueno. Can be mixed with some tremor, astraxis, so tachycardia, sweating, hypertension, emotional outbursts. So if they do have hallucinations, they are typically going to be visual, not auditory. They're usually visual. So again, so the asterisk is usually inability to maintain a sustained posture, usually brief shock-like involuntary movements. If you want to look that up on the internet, feel free. I encourage look up things like this on the internet if you want to see what it actually looks like. Because most of the time you're not going to see normal. So you're going into surgery and there's all types of things that you can look at too. And then you get in there, you're ready to answer questions and rock and roll. To confirm the diagnosis, yep, we can usually make that from the history of physical exam. Helps us out big time because these people are altered. We rely on another person's observing them. Usually a caregiver, spouse, other family members. Again, we want to ask about that patient's baseline is fluctuating severity throughout the day, worsening at night is diagnostic. So you see a PANS question that says they're having altered mental status that is fluctuating in severity during the day, and then it gets worse at night, sundowning, agitation, type of thing. You gotta pick delirium. We can look at a couple other things, make sure that we're looking at their over-the-counter prescribed medications. If they're altered, maybe they're taking too much. I can't tell you how many Tylenol overdoses I've treated because I had an old lady who was having a headache, but she's altered and she just can't remember the last time she took her medication. So she just keeps taking more and more and more. Pretty easy to take over 4 grams a day. Now, check for those drug interactions. You can do that through up-to-date. Get an up-to-date account. You should have that for phase 2. Get half a credit every time you look something up. Half a CME makes it a lot easier. And then what are we looking at? Ultimately, an underlying process. And most of the time, we're going to see that more common than anything is going to be an underlying infection. And there's your 3 flavors. Not necessarily in that particular order, but your physical exam should really give you a good idea what's going on. Fortunately, yes, these older people that are coming in altered, you're going to need to get them terminated. Why? Because we're about skin infections. Where are we going to see those skin infections most likely? Probably in their backside, or if they're sleeping on the front side. However, but that's probably going to be related to ulcers because they're bedridden. This is just for you visual folks if you really want to take a look at there. So just gives you an idea of all these different types of things that it could be. No, I don't need you to memorize this for the test. I need you to be able to differentiate between delirium and dementia. But just realize that this is a pretty wide net you could be casting. Get a good idea of your history of present illness to give you an idea of what's going on. Do they have underlying cardiopulmonary issues? Do they have a history of drug abuse? Do they have a history of neurologic? So So, do they have a history of metabolic types of disorders? Yeah, you're going to need to tease that out, looking at their medication list, because if they have nobody with them and they're altered, give you a good idea to clue in on which one of these has what I want to get down. Yeah, with these, a lot of times we do throw the kitchen sink. We throw the kitchen sink. So probably an iStat right away to check sodium and calcium levels. iStat can do that. If you're ordering a BMP, you're going to have to add the calcium to that. BMP does not have a calcium. You have to add calcium, add magnesium. Want to make sure there's not an underlying liver or kidney issue. So obviously that BMP will help you out with that. GFR going down is bad. Creatinine going up is bad. Urinalysis, looking for leukocyte esterase. Usually the nitrites are a little bit more specific with WBCs. Make sure that this isn't a hypotension, it's not a hypovolemia, so low H&H. Anemia. Increased white blood cells gives us indicative that there's an underlying infection, but keep in mind that stress can cause white blood cell counts to go up. But typically I'm going to see this more around 15 or 16, much more elevated. Chest x-rays are concerned about pneumonia. Most pneumonias you should be able to make the diagnosis on auscultation, hearing crackles, but not always. Not always. Not atypicals, like walking pneumonia, mycoplasma pneumonia. That's going to be a little bit more difficult on physical exam. And then low threshold, especially these older folks, to do a head CT. Am I worried about subdural hematoma? Is it related to having high blood pressure and they ruptured and had an aneurysm?
Yes.
Or is there an underlying mass that's not developed? That doesn't happen for tumors. And then you're not doing need to do an LP. We'll get a little bit more in subarachnoid and the headache special, but low threshold for these people that come in to just kind of throw the kitchen sink. And then obviously we would need to look at, was this a heart-related issue? Just be aware of that. So, mental status examination usually takes 7 to 10 minutes to complete that. That's quite a long time to spend with a patient. So you got to figure out how to make that go a little bit faster. Just keep in mind things that can alter that is how old that patient is, their education level, how long have they been impaired, and then verbal abilities play a big factor in that. So somebody with Down syndrome, somebody that has suffered a significant stroke, sometimes that can make things a little bit difficult. So, here's the other thing is now we can mix in with delirium. So we mix in behavioral health with that. So we talked about these people having bipolar, but depression can sometimes resemble that. But usually we're not going to see them have that rapid fluctuation. Usually not rapid fluctuations. Usually absent within depression. Although both of them can appear to have withdrawal, a certain slow speech and poor results, but just be aware of that. Usually not going to have a problem being oriented and able to perform commands with depression. That's going to be more of a delirium type of issue. So what do we need to do about this? We need to directly treat that. Directly treat the underlying cause. I've listed all those things that it could be potentially. I'm not going to try specific treatments for those, but just be aware of that. So it's very important these people, if they do bring them into the hospital, that they give them the adequate support that they need. That has a lot of psychosocial support. That's why we'll get them up and get them walking if they're able to walk. And then adequate lighting in there helps prevent them from dealing with the fluctuation of somnolence during the day and the agitation at night. If they do get combative, if they do, they require sedation. So first thing you're going to reach is haloperidol. Haloperidol, great medication. 5 to 10 milligrams. I'm never going to ask you on a test for a dosage, a specific dosage, because I need you to get concepts now. I don't need you to memorize dosage. You get a whole year of phase 2 of that. Plus you're going to type in a medication as the dose is going to pop right up. All right, 5 to 10, that can be given PO. If they're too combative, we can do that IM as well. Careful giving old people the healthy dose of that. They don't do well. I don't want to give an old person Haldol and then turn that into compressions. Not fun. Not very usual, but just know some places do recommend atypical psychotics. not a big thing. If you're going to reach for that, we call it a B52. We're going to throw in benzodiazepine, usually lorazepam, right there. 0.5 to 2.0, that can be given PO, IM, and IV. Really just an extra thing to kind of calm them down. Hence the B52, if you hear that term, the other places that will throw in some cogentin, just if they're worried about extrapyramidal symptoms. But very rarely would I reach for Zyprexa or G9. Most of these people are going to get admitted. Unless a readily reversible cause is found. When I say readily reversible, I had a gentleman come in and at night he took his morning dose of insulin to go to bed. It's not good. Luckily he didn't go to bed. He knew he messed up and he got to the ER. So took 5 amps of B50 just to keep him above 80. I call poison control too because technically that's no good. But finally, after about 6 hours, he stayed stable. Was able to go home, and I was, don't do that again. But you know, getting older. Just be aware that was that place where a guy came in super altered, super sleepy. If he'd gone to sleep that night, he probably wouldn't have woken up. But we found the reversible cause. We know what it was. There are a couple other labs just to be safe and send that person home, provided that they have the resources, support network. So some of those are in these 2 means, just the way that goes. Alrighty. Any questions on delirium right now? Everybody's tracking that it's fluctuation. Okay, the intermittent, usually an underlying medical cause, days to hours, versus dementia. Either one can be scary, can be tough. So this is chronic progressive impairment. So affects memory, thinking, and social interaction. So these people can have acute exacerbations, which makes it a little bit more difficult sometimes to make that connection. So, or a superimposed delirium. We should be able to wade our way through that. So usually still need the same type of work. Still can be just as intense. So slow, insidious onset. If it's abrupt, we need to be shifting gears to the delirium realm and thinking of other things. So dementia, folks, I said, so delirium, usually visual hallucinations. These folks can have hallucinations, delusions, develop repetitive behaviors, and because they don't really understand what's going on, these people have a tendency to be very depressed. They know something's going on, and they can't quite understand, and they're getting older. They know something's not right, but they just can't seem to understand. Really gets them in a tailspin. So, loss of that mental capacity, so both psychosocial and cognitive abilities. So, and unfortunately, the behavioral health problems can usually develop. So what do we see there? Largest category right there is that idiopathic dementia. That means we don't really know, but it's usually hereditary, and that's Alzheimer's. And we cannot stop it. We can only slow it down. And then your number 2 flavor is going to be vascular dementia. But just be aware of, if you're ever asked on the PANS, like altered mental status for dementia, there's your number 1 cause, most cases due to Alzheimer's disease. Neurodegenerative disorder. Yeah, I can find some findings using on CT scans, or a lot of that with people have strokes as well. So they don't have it completely understood, but they know that it's very complex pathophysiology. So reduction in neurons, so increases in amyloid deposit, which just doesn't gel with neurons, and then they get these neurofibrilla tangles and plaques, and that'll show up on CT. Most of these people know where that's going. That's why they have these memory care places specifically for these folks. So, vascular dementia, next largest count. So, a lot of time we see that with cerebrovascular disease. What does that mean? Those are people that are higher risk for strokes. So, small vascular types of infarctions, multiple infarctions all over the place. So, as long as it's not a big one, it can be a slower disease process. What do we see with these folks? So usually their memory from like years ago is great. They can remember all the way back to the 50s. They can't remember what happened last week, what happened last month. My grandmother got Alzheimer's, and for the last year of her life, I was cousin Ron. Whatever. Somebody. So, impairment of memory and orientation, but they preserve their speech and motor. So they can talk just fine, they can usually move around just fine. Not typically a fall risk. Not typically a fall risk is what you take from that. So that's that Alzheimer's disease. So you can see potentially other types of behavioral disorders as well as this. Again, depression, anxiety, very common with these folks. If we do see anything that has vascular or multi-infarct dementia related, we're going to see that with deep tendon reflexes. So usually it's going to be exaggerated or they're going to be off based on the left side and the right. Gait abnormalities and then weakness in the extremity. Why? Because sometimes these are just simulated small strokes. Small strokes. So unfortunately very difficult for that generalized physical exam. What I'm getting at there is probably not likely that you're going to call somebody to Alzheimer's or dementia in the emergency department, maybe just dementia, but not specifically making a diagnosis of that. We want to be able to identify if there's any associated causes. If we do find any focal neurological signs, which is why we're going to do a good neurophysical exam, then we need to be concerned that this is more of a vascular dementia, and then concerning probably getting a CT scan to rule out any space occupying lesion or mass. So, and then we talk about what Mr. Michael J. Fox suffered from as far as Parkinson's. So rigidity, movement disorders, we look for those cogwheeling type of things, increased muscle tone, extrapyramidal types of symptoms. What do we do for this? So, like the video showed, so obviously a CBC, CMP, want to make sure that those are KOUA, is not something underlined, but thyroid function test, and then they talked about that B12, and then how do we test for syphilis, what lab? It's an RPR. So, hence the video that I showed you. So, considering some other types of things, and sometimes I'll do this in conjunction with my neuro team. They're not always like they are in that video, so I will pick up the phone and say, hey, I've ordered all this stuff. Is there anything else that you want me to order before you come down and see the patient? Can I tee them up that way? And they'll say, yeah, can you get this and this and this? And that's why they say, hey, I want you to get an ESR. By the way, that's always a send out. And you got back anytime soon. That's going to steer that inpatient team. So, full lengths. That should give you an idea if you saw that CBC and HIV chest x-ray. And then consider imaging on all these folks. You want to make sure that there's not some suicide-occupying lesions. And then consider an LP. A lot of times, if it's dementia related, it's not that acute for me, so it's not something I feel like I need to get an LP. I'll let the inpatient team handle that stuff. Unless I got a resident and I'm like, you want to get an LP? Okay. And it's just the advantages to being in teaching institutions. So, vascular dementia, obviously signs of cerebrovascular disease. So CT scan, sometimes we have a history of coronary artery disease, that kind of big giveaway between that. So, and then we worry about if they having dementia that's been within 3 months of a stroke, so we know that there's that underlying vascular dementia, especially after the stroke. Now there's always a possibility these things can run together and muddy the water, so think of it. Can it be dementia with now we have some delirium that's on top of that and just suddenly altered? So be aware of that if it's suddenly causing a quick change. So we're not just like, it's just dementia, I'm not worried about it. Again, fluctuates really quick. Medical cause, we need to give full court press with that. Just keep in mind, dementia, depression really can mix with that. And then we have something called depression imitating dementia. We're not going to get into zebra pseudo-dementia. Don't worry about that, but just know that it's not always going to be clear and cut. There's going to be some gray areas sometimes. Alrighty, so all these are treatable to some degrees. If they're treatable, I think we could really just slow them down. So sometimes we do need to reach for psychotic or other medications. but just be aware that there are a lot of adverse effects with those. So the increase of cardiovascular events and metabolic syndromes and weight gain. So it's always going to be the double-edged sword. Anytime you prescribe a medication, you need to kind of weigh out the benefit versus the side effects of those. And there are, for some people, you've seen some of these antipsychotics, they say they can increase your risk for suicide. So just be aware of this. It's not always a good thing. So vascular dementia, we want to make sure that we're limiting the risk factors. Usually high blood pressure is the big one we get concerned about that. And then normal pressure hydrocephalus, we have a normal pressure, but again, we can usually see extra large ventricles on the CT scan. So potential, if that's what we're thinking. Now this is probably going to be more of an inpatient type of thing than a emergency medicine thing. I'm usually not going to be doing a trial of LP. Granted, this is diagnostic and therapeutic for this, but it's usually not the case. But things that are going to tip you off to that if they have urinary incontinence and gait disturbances that develop very early. So, new diagnosis of dementia, so we want to entertain that ED, but that really needs follow-up and probably needs to see a neurologist, potentially an internal medicine doctor, a geriatric doctor that is usually dealing with those types of things. So, but, you know, definitely low, you want to keep it low threshold to admit these folks. Low threshold to admit these folks. There's usually a lot more going on. And if they're coming from a memory care facility, that means they probably don't have the capabilities. They're sitting there to get a quick workup and you get it figured out as quickly as possible. Make sure that they're that. Treating your delirium right away. Other things to admit people for is considering comorbid medical problems, and then, as well as rapid progression, atypical cases. If you're in doubt, call your neurologist, make sure you present your patient well, present all your findings, your workup, and say, hey, what do you think? And most of the time I say, hey, can you please just come down and put your hands on the patient, and we'll come up with a plan together. So sometimes they just need to come down and see that patient with their own eyes and make their own assessment. All right, we'll stop right here. Does that sound good? Everybody's probably spent on the first day.